Welcome to QD Clinic. My name is Dr. Eric Dein from Atlantic Health in Summit, New Jersey. Today I'm going to present a case for QD Clinic. Very quick as always, but I'm going to cover multiple visit dates of a challenging patient case. Patient comes in to see me for a new rheumatology visit and tells me that she has long-standing rheumatoid arthritis that had been excellently treated by her prior rheumatologist. Her rheumatologist had a magical cocktail of prednisone 40 milligrams and morphine, and that worked like a charm. She said, "I'm here for a refill of those medications, please and thank you." I said, "Not so fast. Let's learn a little bit about your RA and let's figure out, let's get, of course, a better regimen than that." On exam, there was no clinical synovitis, but she was on a boatload of prednisone. She had lots of chronic pain, hypersensitivity to the touch. I told her that I'd love to figure out a strategy, understand her RA, do some lab work, understand that. I would like to taper the prednisone so I can really get a sense of what's going on with her disease, and if appropriate, start her on the appropriate DMARD RA therapy. I told her that I don't prescribe a band-aid of chronic pain medications, but I work very closely with an excellent pain management colleague. I'd love to have her see that physician and work on this together and get an RA plan for her. She yelled, she screamed, she stormed out of the office because she said, "I didn't care about her RA because I wanted to give her this appropriate medication that has worked for her in the past with opiates and prednisone." I went a while without hearing from her, but a year and a half later, she shows up on my schedule again. So she requested a telemedicine visit. Turns out she had seen a variety of doctors of different specialties who, for a number of red flags, did not feel comfortable giving her any more pain medicines in terms of opiates, and she's been off of those medicines, but in severe chronic pain. She understood what I told her before, that I would be there for her RA when she was ready. And she said she would like to come work on her RA, but she would not be seen in person. She didn't have good transportation. I tried to work on a plan for that, but she was not interested. She also did not want any blood work. She did listen to me, and she came down on her prednisone from 40 to 30 before that visit. And sure enough, she had visible synovitis in her MCPs and PIPs and her wrists on through a computer screen. You could tell that apparently. She had heard about this medication from another doctor that wrecks your eyes, and she didn't want to be on that either. So what would you do in this situation? A, say sorry, without being seen, without blood work and follow up. I can't do very much until you're ready for that. B, emphasize hydroxychloroquine and the safety of it, despite some misconceptions you might have. C, try a trial of DMARDs and not continue it without any follow-up. Maybe she'll see the light with an initial response. Or D, something else. For me, I spoke with her about a variety of options. She opposed the hydroxychloroquine. She was dead set against that. She had heard bad things. Ultimately, she was okay with a trial of minocycline. And I talked to her about it not requiring blood work, and we talked about potential skin pigmentary changes, but she was okay with that potential. And I truthfully wasn't convinced it was going to do the trick for an inflammatory arthritis breaking through 30 milligrams of prednisone, but it gave us a strategy to work on a relationship together. She was willing to work on coming down on the prednisone. She was willing to check in with me. And ultimately, she did feel like the minocycline was working for her somewhat, but not enough. And so she actually had a family member move into town and was able to come in for doctor's offices. And she was eventually amenable to coming on to a conventional DMARD, and we're still working on figuring out a good plan for her. So the lessons from that I learned: number one, meet the patient where they are. You can't put your ideal treatment plan on all patients, and they won't adhere if they don't have buy-in for it. Number two, if there's not agreement, go back and just focus on building trust and a relationship. And from that, things can develop and things can change over time. And when all else fails, if nothing else, minimize harms with medications and do a harm reduction technique. I talked about the prednisone and the side effects, or opiates or NSAIDs, and find the safest regimen, if not the ideal regimen, and work on getting that benefit of disease control with harm reduction. Thank you very much for QD Clinic today. Stay tuned to Room Now for all of RA month. Take care.